Good afternoon. My name is Stacy Van Dusen, and today I'll be doing a brief overview for you regarding evaluation and management coding. What is EM coding? The evaluation and management coding sections are divided into broad categories such as office visits, hospital visits, and office consultations. Most of the categories are further divided into two or more subcategories of EM services. For example, there are two subcategories of office visits, new patient or established patient, and two subcategories for hospital visits, initial and subsequent. Here you will see some CPT coding symbols. Solid bullet indicates a new procedure number was added to the CPT manual. A triangle indicates that a code revision has resulted in a substantially altered procedure descriptor. Plus sign indicates a CPT code add-on code. Circle with the line indicates that the code is exempt from the use of modifier 51, but is not designated as a CPT add-on procedure or service. The two side-by-side triangles, which looks like a bow tie, indicates revised guidelines, cross-references, and/or explanatory text. The bullseye indicates a code that typically includes moderate sedation. The lightning bolt indicates a code for a vaccine that's pending FDA approval. Hashtag indicates a resequenced code. And the circle indicates a reinstated or recycled code. And here's some helpful abbreviations. POS, place of service. CC's chief complaint. HPI, history of present illness. Review of systems. ROS. PFSH is past, family, and social history. SOAP note contains an objective portion, which is the history, an objective portion, which is the exam, an assessment portion, which is the diagnosis, and the plan, basically, is the plan for the patient's care. HX is history. MDM is medical decision-making. CMS is Centers for Medicare and Medicaid Services. CPT is just that, current procedural terminology. And ICD-10-CM is the code book, International Classifications of Diseases, 10th revision, clinical modification. Here's some of the steps that are required to determine the correct EM code. First and foremost, make sure to read the entire patient record. Pick out what keywords will help you define the EM service is performed. Is the patient an inpatient or outpatient? A new or established patient if it's an office visit or consultation? What is the level of physical exam performed? What is the level of medical decision-making required? And once you go through your coding manual or your electronic coders, do you have the most accurate EM code for the encounter? New and established outpatient codes. What is a new patient? New patient is one who has not received any professional services from a physician, qualified healthcare professional, or another physician, qualified healthcare professional of the same specialty and subspecialty who belongs to the same group practice within the past 3 years. Good afternoon. I'm Stacy Van Dusen, and today I will be going over a brief overview for you regarding evaluation and management services coding. What is EM coding? It's the evaluation and management coding sections are divided into broad categories such as office visits, hospital visits, and consultations. Most of the categories are further divided into two or more subcategories of EM services. For example, there are two subcategories of office visits, They're either new patients or established patients, and there are 2 subcategories of hospital visits. It's either an initial visit or a subsequent visit. These are the CPT codes that you will see throughout your CPT coding manual. The top one, the dot indicates a new procedure number was added to the CPT coding manual. The triangle indicates that a code revision has resulted in a substantially altered procedure descriptor. The plus sign indicates a CPT add-on code. The circle with the diagonal line indicates a code that is exempt from use of modifier 51, but is not designated as a CPT add-on procedure service or service. The symbol that looks like a bow tie indicates revised guidelines, cross-references, and/or explanatory text. The bullseye indicates a code that typically includes moderate sedation. The lightning bolt indicates a code for a vaccine that is pending FDA approval. Hashtag indicates a resequenced code, and the circle indicates a reinstated or a recycled code. Here's some helpful abbreviations. For your POS, place of service, CC is your chief complaint, HPI, history of present illness, ROS is review of systems, PFSH is your past, family and social history, SOAP note contains a subjective portion, which is the history, an objective portion, which is the exam, an assessment portion, which is the doctor's diagnosis, and a plan, which is basically the plan for the patient's care. HX is history, MDM is medical decision making, CMS, Centers for Medicare and Medicaid Services, CPT, current procedural coding, procedural terminology, and ICD-10-CM is International Classification of Diseases, the 10th revision, clinical modification. Some steps that are required to determine the correct EM code. Make sure you read the entire patient record. Pick out the keywords that are going to help you identify the correct EM service performed. Are they an inpatient or outpatient? A new or established patient? What is the level of the physical exam performed? What is the level of medical decision making required? What is the most accurate EM code for the encounter? Brief overview of new and established outpatient codes. First off, what's a new patient? A new patient is one who has not received any professional services from a physician or qualified healthcare professional or other physician or qualified healthcare professional of the exact same specialty and subspecialty who belongs to the same group within the last 3 years. Your established patient basically is one who has received professional services from the physician or qualified healthcare professional from the exact same specialty and subspecialty who belongs to the same group practice within the past 10 years. Briefly, your new patient code 99210. Typically about 10 minutes is spent face-to-face with the patient or family. Brief history of the present illness. The exam is problem-focused, just about the affected area. Medical decision-making is straightforward and has one or more self-limiting problems. 99202. You'll see things get a little bit more detailed. 1 to 3 elements of the history of present illness. Review of systems is problem permanent. The past family social history is not applicable. In the exam, a little bit more expanded problem focused, affected area, and the related organ systems. Again, straightforward medical decision making, one or more self-limiting problems, and can be an acute, uncomplicated illness such as cystitis or a simple sprain. Again, we're getting a little bit more extensive. 99203. 4 elements of the HPI. Review of systems, 2 to 9 systems. And in your past, family and social history, one of the 3 is positive. The exam, it's more detail of the affected area and related organ systems. Medical decision making, 2 or more self-limiting problems, 1 stable chronic illness, acute uncomplicated illness, again, cystitis or a sprain. And typically, because this is a little bit more, about 30 minutes is spent with the patient and or family. 99204, again, we're getting a little bit more detail. 4 elements of the history, present illness. You're reviewing 10 of the systems. Past, family, and social history, 1 of each. Comprehensive exam, general multi-system or complete single organ system. Medical decision making. Do they have 3 chronic stable illnesses? 2 or more chronic illnesses, 2 chronic and 1 minor. 1 or more chronic illness with exacerbation, 1 chronic, 1 minor. Undiagnosed, now problem with uncertain diagnosis. Acute illness with systemic symptoms, acute complicated injury. 45 minutes spent face-to-face. 99205. 4 elements of the history. 10 review of symptoms. And at least 1 past family social history. The exam is comprehensive. General multi-system or complete single organ system. 1 or more chronic illnesses with severe exacerbation, progression, or side effects of treatment. Acute or chronic illnesses or injuries posing threat to life or function. Heart attack, pulmonary embolism, or respiratory distress. And also abrupt neurologic status change could be a TIA, seizure, weakness, or sensory loss. Typically about an hour is spent face-to-face with patient and or family. Established patient codes. 99211. This code is used for the evaluation and management of an established patient that may not require the presence of a physician or other qualified healthcare professional. Usually the presenting problem is minimal. Typically about 5 minutes is spent performing or supervising these services. Could be a blood pressure check, giving a flu shot, simple service like that a physician is not required for. Similar to the new patient, 99212, it's established patient code. 1 to 3 elements of the present history, present illness. Review of systems pertinent to the problem. Exams problem focused. Medical decision making is straightforward. 1 or more self-limiting problems, acute uncomplicated illness. Roughly 10 minutes is spent with the patient. Again, similar to the new patient codes, 213, a little bit longer, 15 minutes. History is the same, but it's an expanded problem focused, a little bit more detail in the medical decision making. 99214, getting more detailed. 4 elements of the history of present illness. 2 to 9 systems reviewed. 1 of 3 of the elements of the past family or social history. It's a detailed exam. Your medical decision making is expanded. And about 25 minutes is spent face-to-face with the patient. 99215, 4 elements of the history of present illness. All 10 systems are reviewed. 1 each of the past family social history. Comprehensive exam. Medical decision making. It's definitely high complexity. 1 or more chronic illnesses with severe exacerbation. Acute or chronic illness posing threat to life or function, or an abrupt neurological change. 40 minutes or more spent with the patient and or family. This table will give you a guideline, help give you a guideline on medical decision making. As you can see, straightforward, everything is minimal. Low complexity, limited and low. Moderate complexity. Multiple, moderate, moderate. High complexity. Again, that's your potential life, limb, neurological issues. Extensive number of diagnoses or management options. Extensive amount or complexity of data to be reviewed. And a high significant risk of significant complications, morbidity, and or mortality. Here's an example of some evaluation and management tables that will help you in coming up with the correct EM code. And I have included these in a coding tool that you can use on a daily basis to help you. Again, another excellent coding tool. Color-coded, and it gives you chief complaint, history of present illness, your review of systems, past family social history, the body areas, the exam component. And here it helps you break it down by the patient history. Are they a new patient or an established patient? Your examination, problem focused, expanded problem focused, detailed, comprehensive. Your medical decision making, straightforward, low complexity, moderate complexity, high complexity. Again, new patients, established patients. Here are some helpful coding sites that you'll find very helpful. Find a Code is my favorite. Then the ICD-10-CM code. Also the 3M coding site under AHIMA. And then the Nuance Coder, which you'll find in the Quantum AHIMA site. In closing, this is just basically a brief guideline to help you understand and learn some of the EM coding process. It gets more detailed. You'll find in the CPT coding manual under the EM services section. Are there any questions? And these are the references that I used to build my PowerPoint and my evaluation and management coding tool. Thank you for your time and attention, and have a wonderful day.